Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. So we'll go ahead and get started. I'm excited to welcome our presenter to today's program, Shining a Light on Myelofibrosis. Dr. Carlos Franco has been generous to do some of these educational programs for us in the past, and we're so happy to have him back on this virtual platform. Dr. Carlos Franco is board certified in medical oncology and hematology. He practices with Georgia Cancer Specialists out of these Center Point and Alpharetta locations. Dr. Franco is a member of the American Society of Hematology and the American Society of Clinical Oncology, and a fellow of the American College of Physicians. He has a special interest in malignant hematologic disorders and benign blood disorders. So with that, welcome, Dr. Franco, and I'm going to pass it off to you to get us started.
Thank you so much. Good morning, everybody. First of all, I want to say thank you to Katie and Eric, who helped me set up this presentation in my computer here at the office. And the other thing I want to say before I start is that I always enjoy the human touch. So I've done some of these programs, but I truly enjoy doing it in person so I can meet you and see your faces and interact with you and have a little lunch. But anyway, this is where we are now. So we'll go ahead and start. As Katie said, I'll be happy to answer any questions at the end. I'm going to go through the slide set in some cases very fast because this is a very long slide deck, and I may be using only 30–40% of the slides. The others are not as important. And I will also make a stop at some point to talk a little bit about what we call staging of my fibrosis, which is not in the slide set, which is also important so you understand how we treat depending on the stage of the condition and what the prognosis is. Yes, in the bio, Katie said that I have a special interest in malignant hematology and also benign hematology. Yeah, that's exactly, that's very true. I do oncology, but in my heart, I'm a hematologist. So that's why I enjoy doing presentations like myelofibrosis and other conditions of the blood. Now, we are here to talk about myelofibrosis, which is a disease of the stem cells in the bone marrow, and hence the disease of the blood. So we're going to talk about the myeloproliferative neoplasms. We're going to talk about different kinds of myelofibrosis, clinical aspects, laboratory tests, complications, and what we can do to improve your condition. Now, in the past, we used to talk about what we call myeloproliferative disorders. Some time ago, the name was changed to myeloproliferative neoplasms, which is a group of conditions where generally we see an increased production of blood cells in the bone marrow. And there are several conditions. One, the hallmark is what we call chronic myeloid leukemia, which is considered separate because this condition is associated with the chromosomal change, which is called Philadelphia chromosome. We're not going to be talking about that condition today, because it really has nothing to do with the fibrosis, but it's one of the conditions in this category of diseases. The conditions that we're going to be talking about is mainly the fibrosis, myelofibrosis, either primary, that appears in patients who never had any hematologic condition before, or what we call secondary myelofibrosis. And secondary myelofibrosis could develop in patients with a prior history of polycythemia vera, which is a condition in which the bone marrow makes too many red blood cells, or following a condition that is called essential thrombocythemia, in which the stem cells in the bone marrow make too many platelets. But many times in 5% of patients or so, perhaps 10% of patients, there is transformation into fibrosis or development of scar tissue in the bone marrow, which is called fibrosis. Now, again, a myelofibrosis or myeloproliferative neoplasm means that this condition develops in the bone marrow. Myelo is bone marrow. That's what the Greek word for bone marrow. And when we call about myeloproliferative, proliferative means growing or reproducing rapidly. So myeloproliferative is a disease of the bone marrow in which the stem cells in the bone marrow are reproducing or growing fast. And neoplasm is basically neo from the Greek new and plasm meaning formation of new tissue, out of control growth of cells that really don't do anything. They don't function. They are abnormal cells. Neoplasm usually refers to new growth, but generally we call neoplasm a malignant disease, a cancer type disease. And this in a way is a type of cancer of the blood, okay? Now, when we talk about tumors or cancers, we talk about solid tumors or liquid tumors. Solid tumors are cancers or tumors, new growth of organs, solid organs like lung, prostate, liver, breast, stomach, ovary. So, solid tumors are tumors of mast cells that are usually malignant. They could be benign, in terms of, a tumor could be benign or malignant, but we refer to tumors usually to cancerous tumors or malignant tumors. Now, liquid tumors are present in the blood and in the bone marrow. Okay, so the bone marrow is a liquid organ inside the bones, and it produces blood cells. So liquid tumors are tumors of the bone marrow or tumors of the blood. And we generally, or most people know about leukemias, acute leukemias, chronic leukemias. Those are liquid tumors or liquid liquid diseases, generally malignant. And myelofibrosis belongs to this category of liquid tumors. Now, as I said before, many times the myelofibrosis develops in people who already have a clinical condition, like polycythemia vera, and P vera is present in about 100,000 patients in the US, essential thrombocythemia or excessive production of platelets, about 71,000 people in the US. Primary myelofibrosis, though, is rare. So all these conditions are rare, but primary fibrosis, development of scar tissue in the bone marrow out of the blue, is less common than other conditions of the blood or bone marrow. About 16,000 to 18,500 people in the US live with this condition. Okay. Now, pronunciation, not that important, but anyway, myelofibrosis. Myelo is from the bone marrow, fibrosis is a scar tissue. The pronunciation is myelofibrosis. Now, the origins is basically we consider fibrosis or chronic myeloproliferative neoplasms diseases of the stem cells. The stem cells here are located in the bone marrow, inside the bones, and these are the cells that produce blood cells. We are born with billions of stem cells to last a lifetime, and these cells produce red blood cells, produce white cells, and produce platelets. Now, genetics. The bone marrow makes about 200 billion red cells, 200 billion red cells, and 10 billion white cells every day. Okay? Now, every time a new cell is made, the stem cell or the parent cell has to divide into two cells. Okay? Consider how many times the stem cells do this a day. 200 billion for red cells and 10 billion white cells. So they are likely to make a mistake rarely or every once in a while. Now, every cell division requires a copy of the entire DNA of the cell to be passed on to the new cell. So the entire copy of the entire DNA of each cell to be made by the cell. So 3 billion nucleotides of DNA need to be copied each time. These are the small units are the nucleotides and the DNA helix. And again, every time there is a new cell, there are 3 billion nucleotides of DNA that are being copied. So if we consider this massive undertaking, it's easy to understand that rarely, but sometime it's just going to happen. The stem cells or the division is going to be faulty, or the cell is going to make a mistake. As I said, mistakes happen. There are 17 mutations that develop in every stem cell each year. Okay, so if we have 100,000 stem cells in an adult at a given time, this is about 2% of our DNA that codes for protein production. There is a protein mutation every 15 minutes. So there are mutations that develop during the division of the cells. When the stem cells produce blood cells, there are mutations that occasionally happen. There is a mutation every 15 minutes. In the overwhelming majority of patients, these mutations are meaningless, or they don't really cause any problem, or they develop, but they are not pathologic mutations that lead to disease. Okay, now, genetic mutations, though, that are associated with these conditions affect the way the cells communicate. And this is what we call cell signaling, okay? So, again, mutations happen, but mutations are much more common as we age. Mutations under the age of 40 are rare. Mutations over the age of 60 are common. A gene mutation is a permanent alteration in the DNA sequence, okay? It could be hereditary. There are conditions that where kids are born with hereditary conditions that come from mutations in the DNA sequence. But those are rare. Most are acquired, or what we call somatic mutations. The longer we live, the more exposure we have to things that can cause somatic mutations. Viruses, chemicals, radiation could cause somatic mutations. Cigarettes cause somatic mutations. So mutations are not common in patients 40 and under, but the likelihood increases significantly after the age of 60, as you can see here. The number of mutations before 40 are essentially non-existent, but you see that it increases after 40, even more after 50, and then finally after 60 and 70 and 80, it takes off. It takes off, yeah. So mutations driving myelofibrosis are several. There are what we call non-random chromosome abnormalities on several chromosomes in chromosome 9, 20, 13, 8, or 9. And these mutations could develop in patients that already have fibrosis in the bone marrow, or people who have another condition that is called myelodysplasia, where it's many times present within a patient with myelofibrosis. Myelodysplasia means changes in the stem cells, somatic changes, chromosome changes in the stem cells that lead to defective production of blood cells, with or without fibrosis. And many times, as I said, we see patients that are diagnosed with myelofibrosis in the bone marrow that also have chromosomal changes that are present in people with myelodysplasia. Now, the most common mutation is called JAK2 in 50% of the patients. Okay, JAK2 mutation that develops in these patients that leads to this condition or progression. Mutations are also present in a receptor of what we call MPL, myeloproliferative leukemia, MPL, in 5% of patients have mutations of this receptor gene. and also mutations in CALR gene, the calreticulin gene, CALR. CALR is found in 73% of patients that do not have the JAK2 mutation. So if we generally test for the JAK2 mutation, but if the patient is negative for JAK2 mutation, we test for CALR mutations. And if the patients don't have CALR mutations, we test for the MPL mutation, which is less common. But those are the three most common mutations that develop in patients with myelofibrosis and other myeloproliferative neoplasms. In more than 90% of patients have mutations in myelofibrosis. More than 90% of patients have mutations either in JAK2, CALR, or MPL. Okay? 60% of patients have mutations in additional genes. Okay? 10% of patients may have mutations in other genes or may have no mutations. Okay, so these are mutations, for example, TET, AXL, DNMT3A. These are mutations that are generally present in patients with combined myelofibrosis and myelodysplasia. Okay, so generally these patients have abnormal mutations in the chromosomes. Disease progression in MPN. Before I tell you about this, I want to tell you a little bit about the slide that is not here for staging of myelofibrosis. And then I'm going to make a comment about my experience with my patients. Myelofibrosis is generally in three stages that is evaluated in the bone marrow. Myelofibrosis 1, grade 1, myelofibrosis 2, and myelofibrosis 3. And that depends on the amount of scar tissue in the bone marrow. Okay? Now, when we have patients with grade 1 myelofibrosis, those patients generally live many, many years. And I want to mention three patients in particular that I've seen or that I've had for more than 20 years. These patients presented with an anemia. We found that they had fibrotic tissue in the bone marrow, and they had some mutations, and with or without an enlargement of the spleen. Okay? These patients have been alive for more than 20 years without significant progression of disease. So the fact that you have myelofibrosis, if it is early, then this is not a death sentence. We can survive for many, many, many years without any problem. Grade 2 survival is less, perhaps in the average of 10, 15 years. Grade 3, less than 5 years. So when you have severe myelofibrosis, then you're likely to get complications within 5 years or die within 5 years. Okay, now, in terms of the progression of myeloproliferative neoplasms, including myelofibrosis, there are three phases: a chronic phase, where the patients have either an anemia or elevated platelet count, then accelerated disease progression, the second phase, in which case we see mainly progression of the spleen size. A patient that, for example, had a spleen that measured 13, 14 centimeters, and all of a sudden the patient comes to the office and says, "Doctor, I hurt in my left side, in the upper side of my abdomen on the left side. It's hurting. And I start eating and I get full very quickly." That is evidence of progression of the splenomegaly. The spleen grows fast and it goes to 20, 25 centimeters and it begins to cause trouble. Or the leukemic transformation. About 5% of people with these conditions could transform into acute leukemia in their lifetime. So let's say that a patient has a grade 2 myelofibrosis or stage 2 myelofibrosis, and you diagnose that, and the patient is fine, has a little anemia, some elevated platelets, and you don't do anything, just follow the patient. But 3-4 years later, the patient develops acute leukemia. So that could happen even in early stages of myelofibrosis, but it's way more common in more advanced stages of myelofibrosis. 5% risk of transformation into acute leukemia that requires a different treatment. Okay, now, one thing that happens very often is what we call molecular evolution or transformation. So let's say that we diagnose myelofibrosis and the patient has a JAK2 mutation. but the patient 5 years later experiences progression of anemia, progression of splenomegaly, and you do another bone marrow or molecular testing in the blood, and you find that now that patient has more genetic mutations or more problems in the molecular studies. And well, anyway, let me see. Okay, so summary: myeloproliferative neoplasms are caused by mutations in JAK2, CALR, and MPL, and other mutations. There are variable speeds of growth of these abnormal clones, generally slow, but that really depends on the degree of myelofibrosis at the time of diagnosis. Mutations are generally acquired in the first half of life, sometimes very early indeed, but they don't cause any trouble until later in life. Mutation acquisition is a normal part of our lives and occurs in all cells in all humans. Some are meaningless, some are not pathogenic, some lead to disease. Understanding what influences the growth rates and slowing them down could enable preventive strategies in the future. Now, with regards to myelofibrosis, clinically speaking, we see in the clinic, I'm not talking about the bone marrow, we already talked about 1+, 2+, 3+, or grade 1, 2, grade 2, grade 3, or stage 1, stage 2, and stage 3. This is clinically what we see in the clinic when the patient comes to see us, not in the bone marrow biopsy. Proliferative phase of myelofibrosis. When we have a patient that comes in a proliferative phase of myelofibrosis, we see leukocytosis or elevated white cells, normal platelets, mild or no anemia. Now, I take I don't agree exactly with the normal platelets because many patients also present with elevated platelets, but they could come with elevated white cells, normal platelets, or anemia, but they could also have elevated platelets. This happens more likely after you have essential thrombocythemia or polycythemia vera for a few years, okay? The scores, the risk scores are lower, so the patients have less risk of transformation into leukemia and less myelofibrosis, more splenomegaly, which could be present in patients with polycythemia vera even before they develop myelofibrosis, higher JAK2 mutation levels, better outcomes, less risk, better outcomes, and more treatment options in patients who present with proliferative myelofibrosis. I mean, with elevated white cells, elevated platelets, and anemia. Now, the cytopenic myelofibrosis has worse prognosis. The patients already present with low numbers of cells, low platelets, anemia, normal or low white blood cells. So they feel bad because they have an anemia. They have low platelets, so they could have bleeding or bruising. Now, this presentation is more likely seen in patients with primary myelofibrosis that have a higher risk factor for progression, more leukemic cells, more fibrosis, lower JAK2 levels, high molecular risk. If you do a genetic study in the blood or in the bone marrow, you're going to find more mutations or abnormal chromosomes that are associated with higher risk or poor prognosis. Worse survival, higher leukemic transformation, and fewer treatment options. We're talking about, again, when patients present with low white cells or platelets or red cells as opposed to higher numbers. Now, cytopenic myelofibrosis is associated with lower blood counts, more anemia, lower red cell counts, lower platelet counts, and genetic mutations other than the JAK pathway, other than the JAK2 mutation, mutations that are more associated with myelodysplasia or with a higher risk myelofibrosis. And cytopenic myelofibrosis has a worse prognosis, as I just said. Okay, myelofibrosis could affect the quality of life. Why? Because there is abnormal blood cell production. Patients present with anemia. Many times they present with a big spleen, or they could also present with bleeding problems or venous thrombosis or other health complications that I'm going to be talking about. Or they may also present with symptoms like fatigue, night sweats, itching, muscle pain, joint pain, fever. So many patients may present with symptoms. Other patients may present with some signs that the doctors identify. Now, the spleen could become enlarged. And as long as the spleen, let's say, the normal size is 12 centimeters or less, your spleen could grow to 14, 15, and you may just feel fine. But when the disease progresses, the spleen grows even more, and the spleen takes room in the abdomen and presses against other organs like the stomach. So you start eating and the stomach is compressed. There is pressure on the stomach, so you cannot eat that much because the stomach gets full quickly. And with the growth of the spleen, you could also experience pain or discomfort in the upper abdomen. Now, again, when you develop symptoms, which are generally seen in more advanced presentations of myelofibrosis, like the cytopenic myelofibrosis that presents with 2+ or 3+ scar tissue in the bone marrow. You can have early satiety, so you eat and you feel full quick, sort of depressive mood, weight loss, cough, fever, night sweats, dizziness. You're so fatigued that you don't want to do anything, and many times you have joint pain and muscle pain. And if the marrow is replaced by scar tissue, mostly in grade 2 and 3, then you're going to see reduced platelets, reduced red cells, and the white cells may be reduced too. So if you have an anemia, you're going to feel tired. Now, 86% of patients with myelofibrosis present with some fatigue. Is the main complaint. Some patients may have an anemia that requires blood transfusions. And that begins to affect the quality of life of the patients that have to go to the hospital on a regular basis, monthly or every 2 months, for blood transfusion. So the patient is tired, so he doesn't want to do anything. And transfusions may cause what we call, the most important is iron overload. If we need to give you too many transfusions during a year or two, then your body is going to end up overloaded with iron. And that could cause diabetes, it could cause arthritis, it could cause low thyroid function, it could cause liver disease, it could cause heart disease. So there are problems that could come not only from the disease, but also from the transfusions. Because every unit has about 125 milligrams of iron, and then up to 250 milligrams of iron. So basically, that iron goes into the blood and doesn't come out. So it's stored in the liver or in the heart or in the pancreas. So you develop diseases. Laboratory testing, we have talked about. We do, the main thing is blood count, the complete blood count with differential. So we measure the white cells, the platelets, the red cells, but differential is the different types of white cells. White cells are not just one type. We have many different types of white cells. Neutrophils, we have lymphocytes, we have monocytes, we have eosinophils. So basically we have to do the whole differential. And we just take blood from your vein, and it has, in all of these conditions, we require a blood count every time the patient comes to the office to see if there are any changes. Now, normal hemoglobin, which is the protein in the red cells, is 12 to 15.5 about in a woman. Generally, a woman that bleeds every month for 30 years has a hemoglobin in the 12.5 range. So a 12.5 for hemoglobin is normal for a woman, but it's not normal for a man because we don't bleed every month for 30 years like women do. So usually normal values for men are over 13.5, and I would say over 14. So that's normal. White cells are up to 10,000, 3,500 to 10,000, and platelets, as it says here, 150, no, 140,000, actually, 140,000 to 440,000, about that. So those are the normal levels. So if a woman presents with a hemoglobin of 9, that's a significant anemia. Or a man that presents with a hemoglobin of 11 is already a significant anemia for a man. So, and then we do chemistries. We check liver function, we check kidney function, we check protein levels, immune system, globulin levels. So we may or may do a bone marrow aspirant biopsy at the beginning, but at the end, every patient needs a bone marrow biopsy to check for fibrosis or scar tissue in the bone marrow. And then we do mutation tests. In the past, we did the mutation test, the molecular testing in the bone marrow. But for the last few years, we've had what we call NGS, next generation sequencing studies that we can do in the blood. And we can identify many mutations or most mutations with the blood test. JAK2, CALR, MPL, other mutations for myelodysplasia can be easily tested in the blood. The EPO level is EPO is a protein that is made in the kidneys in response to anemia or oxygen concentration in the red blood cells. So EPO levels are important to test because there is a drug or a protein that is called erythropoietin that is produced in the kidneys, that is produced in the laboratory by genetic techniques that increase the amount of EPO, and they can concentrate the EPO and they can give it to you in an injection. There are several names: Procrit, Epogen, Aranesp, several names. And we use erythropoietin to treat anemia in myelodysplasia, and also in myelofibrosis without a huge spleen. And that increases the production of red cells. And we measure the EPO level, because if the EPO level is too high, then patients usually don't respond to erythropoietin. But if the EPO level is low or normal, then we give erythropoietin because patients respond generally. Generally no more than 50%, but it could help many patients. And if the patients are treated with EPO shots, they have required transfusion of blood before, with the EPO shots, they may not need blood transfusions again for a while. Now, let me see, complications. Again, most people with these conditions are diagnosed over the age of 50 or 60. You check for the spleen, you check for anemia, and you have to do a bone marrow biopsy for this. Now, one of the complications of myeloproliferative neoplasms, including myelofibrosis, is thrombosis, venous thrombosis. And these patients are generally treated before they develop thrombosis for prevention of thrombosis with a baby aspirin daily. So we tell them, patient, okay, but before we put them on aspirin, we check the platelet function. Even if the platelets are high, sometimes we check the platelet function to make sure that the platelets are working, because 50% of the patients generally are at higher risk for thrombosis, but 50% are at higher risk for bleeding because they have platelets that don't work. So we can easily test a diagnosis. We can easily test the platelet function with a test that is called platelet function screen. If the platelet function screen is normal, the platelets are normal in the function of the platelets, then we can use aspirin in those patients to prevent thrombosis. But if the platelets are not working well, then you cannot give aspirin, because you can make the patient bruise badly or bleed because the platelets are already defective. So we have a way to evaluate the platelet function before we start the aspirin in these patients to decrease risk of blood clots, thrombosis, like thrombosis in the legs, thrombosis in the lungs, in the portal vein in the liver, heart attack, strokes, peripheral vascular disease. All of these conditions could develop from these in patients with these conditions. So we try to prevent these conditions, or we try to treat them as soon as we find them. Now, patients with P. vera or even fibrosis could also have gout, because the turnover of these cells is so high these cells are defective. The bone marrow is producing too many blood cells, but these cells are defective. They are not normal cells. They don't have the function of normal cells. So when they die, and this is called apoptosis, they have increased apoptosis. The dying rate, the death rate of the blood cells that are defective in these conditions is very high. For example, a red blood cell is supposed to survive 120 days. In these conditions, the red cells are defective. They die in 30, 40 days. That's why the patients develop an anemia. And when they die, when the white cells die, generally, or the platelets, but mostly the white cells, they release uric acid. And uric acid causes gout. And this happens mostly in polycythemia vera, but it could also happen in fibrosis. So there are patients come with gout or with thrombosis, or there are patients that come with bleeding, or if the blood clot is in the portal vein, they may come with portal hypertension and the spleen grows because of that. They may come with infections if they have low white cells, or they could progress to leukemia, but the progression to acute leukemia is only 5%. Now, again, we talked about the discomfort from the big spleen. You can have itching, you can have bone pain, muscle pain. You can get full when you eat too soon. You can have weight loss. You can have weakness, fatigue, fever, night sweats. So there are many things that happens. Some patients have symptoms related to the spleen. Other patients have symptoms related to the overall condition, the disease, like these symptoms that I just told you: fatigue, night sweats, fever, and all that, muscle pain, and all that. So now, again, the symptoms: fatigue, early satiety, abdominal discomfort, night sweats, bone pain, itching, fever, weight loss. So all of that we have to evaluate for. Now, let me see, let's go, because I've talked for about 35 or 40 minutes already. So this is very important. The management. How do we manage fibrosis or these conditions? Again, remember that some patients present with too many blood cells, other patients present with too little. They don't produce enough cells. So depending on the condition, many times, most of the time, we don't do anything. We just watch. We just watch the blood counts. For example, if a patient presents with a platelet count that is high, a white cell count that is high, but the patient doesn't have any symptoms and has an anemia with a hemoglobin of 11, then there's nothing we need to do. Hemoglobin of 11, in most cases, is safe, and we just watch. Obviously, depending on the other conditions that the patients have, because remember, these patients are usually over 60 and they have heart disease, or they have diabetes, or they have high blood pressure, or they have other conditions. So you need to consider the whole thing. It's not just we don't treat diseases, we treat patients. So we have to consider that these patients may have other conditions. But generally, let's say you have a hemoglobin of 11, we don't do anything. Now, in the past, for example, just to give you an example, when I started my practice 35 years ago here, we didn't have EPO shots. Within a few years, we started having those EPO shots for the anemia, and Medicare and other insurance companies used to pay for patients with a hemoglobin under 12. Okay, so if you had a hemoglobin of 11.8, I could give you the EPO shot. Then 10, 15 years later, that changed. Now they pay only for hemoglobins under 11, okay? Fine. So we couldn't do it on 11.6. We had to do it on 10.8 or something, okay? Then now, over the last 5, 8 years, it's only hemoglobin under 10. So we cannot give you an EPO shot unless your hemoglobin in the red cells falls under 10. Now, I have to say that in a way is saving money. And I agree with saving money from expensive medications. But I think that there is a point that is important to remember, that I tell my patients that, yes, there has been a change, but generally, patients that are, let's say I have a 75-year-old person with a hemoglobin of 10.5. Obviously, the patient may feel fatigued, okay? But I cannot give him the EPO shot, okay? Because he's not under 10 yet. I guess the rationale is the 75-year-old patient who may have diabetes or heart disease or other conditions is not going to go over there and play football. And that is basically, so that patient he's probably not going to have a job that requires him to carry 50-pound boxes, you know, whatever. So basically, is the fact that the activity is not that heavy burden in patients that are older. So they don't really need a hemoglobin of 14 or 12. Okay, but we never discriminate on the basis of age, but insurance companies have their guidelines. I could not give you an EPO shot unless your hemoglobin is less than 10. Now, when the symptoms develop or patients who present with symptoms, again, we could use the EPO shot to improve the production of red cells. We could give you a baby aspirin to decrease the risk of clots. We could give you a Tylenol, or to decrease the fever, pain medications, or decrease risk of bleeding. We can also do that. Now, there are therapies that these patients may need, all the way from transfusion of red blood cells to stem cell transplants or to medications. Generally, if a patient presents with a severe anemia, we have to give transfusions and we do EPO shots, okay? If a patient presents with polycythemia vera with very high red cell counts, we have to do phlebotomy. We have to remove blood. But again, we're mainly talking about myelofibrosis here. There are some patients whose spleen is so big that many times we use radiation to reduce the size of the spleen, or surgery, okay? But now we don't do that anymore in many patients because we have drugs that are called JAK2 inhibitors. So we can use ruxolitinib, like Jakafi. We can use pacritinib or fedratinib, which are drugs to treat myelofibrosis and to shrink the spleen. And now in many cases, we don't need to do surgery or radiation because we have the drugs that can shrink the spleen. Stem cell transplants, allogeneic from another person, are used in younger patients with progressive myelofibrosis or myelofibrosis 2 to 3. Okay, they are not used in older patients, mainly again 40, 50 patients in the 40s and 50s, because the toxicity is really significant in older patients. But it really depends. If the older is I have a 70-year-old patient who has no other medical condition, I will send him for a transplant consult, obviously, because that patient has an excellent health otherwise. So he could tolerate a transplant much better than a patient that has diabetes and high blood pressure and gout and all that. So now, again, that's the mainstay of treatment. The most significant treatment that we have now for myelofibrosis is JAK2 inhibitors. Other drug therapies, we can use hydroxyurea. Let's say the patient presents with 1.5 million platelets. Okay, we can reduce the platelet number by using hydroxyurea. Or if the red cell count is too high, we can use hydroxyurea. If the white cells go to 80 or 100,000 and it's not acute leukemia, then we can use hydroxyurea to decrease those numbers. But the main treatment now for fibrosis is JAK2 inhibitors. And JAK2 inhibitors could reduce the size of the spleen significantly or could eliminate symptoms. I remember fondly this lady who, I saw the husband, and the husband had polycythemia vera for many years. And he had been my patient for many years watching. All of a sudden, he develops progressive myelofibrosis and comes to the office with fevers every day, night sweats, muscle pain, weight loss, left-sided pain. I mean, he was a mess. I mean, this guy who was very active despite his PVera, all of a sudden he's sick, and he's sick for 2 or 3 weeks, and the wife brings him. And then I do the bone marrow. I diagnose myelofibrosis now. Okay, I put him on ruxolitinib, Jakafi. A week later, he comes to the office without any symptoms. And the wife brings a big, Tupperware filled with baked cookies and says, "Thank you, Dr. Franco, for giving me my husband back." When I'm telling you this, because when these drugs work, they work remarkably. I mean, the symptoms could go away very quickly, or the spleen could shrink in a few weeks. So it's important to use these drugs. Anyway, there are obviously clinical trials, but clinical trials for these patients are not up front because we really don't have anything that is, earth-shattering or something that is significant in right now. There are clinical trials with the new drugs for Jakafi. It's always important to consider clinical trials, but usually at the beginning we use transfusions, we use EPO, we use Jakafi. So then if the patients don't respond, we send them to clinical trials. Now, let's see. I think that's probably it. I think Kate is going to give you some information about some support systems that we have for patients with MPNs or myelofibrosis. Katie, you want to take over?
Yes, thank you, Dr. Franco, for all of that information. I'm going to quickly share my screen to share with you some additional resources. All right, so some resources that are available. I want to hit, of course, Cancer Support Community Atlanta. There we go. Cancer Support Community Atlanta. We offer free virtual and in-person oncology support programs. We have support groups. We do also have a weekly support group I want to highlight that is led by a licensed mental health professional with us. We have some great stress reduction classes. If you're looking to connect with something like yoga and Tai Chi, we have those kind of programs, really a wide variety of stress reduction classes, which does include a breathing technique class that we're going to get a little sample from in a little bit. We have monthly nutrition seminars that highlight various oncology topics, and those are led by an oncology dietitian with Northside Hospital Cancer Institute. We also have a monthly nutrition seminar for those newly diagnosed, where we talk about eating and nutrition during treatment. And so for a full list of our programs and how to connect to those, I encourage you to visit our website, cscatlanta.org. And if you ever miss a live program or know somebody who missed today's live program, you can find a recording under the video library tab on our website. I also want to highlight a couple programs through the Leukemia and Lymphoma Society, who has graciously partnered with us today on this program. They have some great resources in the way of education, support, financial support. So you can see the education resources. Some are listed here in the way of free printed materials. They have libraries and even podcasts, so check those out. They also have a wide variety of support groups and can offer various kinds of financial support. So I do encourage you to visit their website, lls.org, so you can see a complete list of everything that they have to offer. And if you're looking to download any kind of myelofibrosis educational material, please visit our headquarter company, Cancer Support Community. If you click that education tab, you can find some great downloadable information there. So I encourage you to visit that. I'm going to put all of these links in the program chat box. So before we get to our breathing technique class, I do want to encourage everybody, if you have questions, please enter them in today's program chat box for Dr. Franco. And while people are doing that, Dr. Franco, I'm going to jump to a couple questions that we got. Earlier in the program, you mentioned some of the advantages of recognizing MF in early stages. Do you mind just revisiting kind of what those symptoms may be and maybe how you can say, oh, this is definitely MF versus maybe some other things that the symptoms might replicate?
Yeah. Generally, in early stage MF, there are no symptoms, because the patients generally present only with a malanemia or an elevated platelet count. Spleen is slightly enlarged. So generally, patients just feel fine. And in the overwhelming majority of patients that I have seen, and again, you need to remember, these conditions are very rare. But what I've seen in early is patients who present with anemia or present with elevated platelets, or present with a spleen of 14, 15 centimeters. That was not that big. So, and the 3 patients that I just mentioned that have survived over 20 years, they presented with anemia, the 3 of them. One of them with elevated platelets also, and the other one with a spleen about 14, 15 centimeters. So many times it's just a consult from the, in most cases, it's just a consult from the primary care doctor for anemia or elevated platelets or splenomegaly. But again, nothing earth-shattering. So it's just mild splenomegaly, mild anemia, mild elevation of the platelets, usually in early stages. Yeah, there is no symptom. I guess the question may have to do with warning. What would be a warning? No, it's really no warning in early stage. Early stage is usually a condition associated with no symptoms that you can tell about. Yeah, you go to the primary care doctor for a routine physical exam, yearly physical exam, and he says, "Oh, you know, your Mrs. So-and-so, your hemoglobin last year was 12.8, and now it's 11." Okay, that basically triggers the consult with the hematologist. Or for example, you have gallbladder problems, okay, and they do an ultrasound of your abdomen just to check for gallstones, and they see, oh, there are gallstones, but the spleen measures 14 centimeters. Then that's a referral to the hematologist. Or you go for a visit, and Mr. Smith, your platelets last year were normal, and this year they are 650,000. You need to see a hematologist. So that's generally what it is. Yeah. Go ahead.
Okay, thank you. And I know early on in the program you had mentioned that MPN is really rarely a hereditary disorder. Can you go back to that? A patient had a concern that they had a history of it in their family, and is there anything, should they do increased monitoring to kind of see if they have it as well?
No, for genetic, the most common genetic MPN is juvenile CML, juvenile chronic myelocytic leukemia. That's an acquired condition. That's not hereditary. That's not genetic. That's not, you are not born with that. When I mentioned that, I wasn't really referring to the MPNs. I was referring to the, I was talking about that when I talked about the genetic testing, the DNA testing, and also trying to explain the mutations in the DNA helix, in the DNA makeup of a patient. And what I was saying is that there are kids that are born with genetic conditions that are due to genetic mutations in the chromosomes that affect blood cell production. But those are diagnosed early in life. Okay, those are diagnosed early in life. That's different from acquired conditions that you develop during your lifetime, acquired mutations. Okay, so now, hematologic malignancies run in families. Yes, that's something that wasn't clear to us in the past, is more clear to us now because of recent studies. But again, it's not a huge difference. No, I mean, let's say that your mother had chronic lymphocytic leukemia and your grandfather had a small lymphocytic lymphoma. Then obviously you are at higher risk to develop a leukemia or a lymphoma, but I'm not talking about 60% higher than the general population. No, 4%, max 7% higher. So there is a higher likelihood if you have a member in the family that has had a leukemia. But again, it's not huge. It's not something that is overwhelming. No, it's 3-4% for some conditions. For myeloma, it's a little bit higher because myeloma is more common in African Americans. So it's a little bit higher when you have a myeloma, an uncle that has myeloma, and your great-grandfather had myeloma, then your risk is a little bit higher. But again, it's not a huge difference, but it's a statistically significant difference. Yeah.
Okay, thank you. And I think this question might align with that previous one too, is the JAK2 gene mutation genetic?
Yes. What is the question? Oh, the JAK2 is acquired. The JAK2 is not a mutation that you are born with, or that causes a genetic, or that you are born with, or that you could have at birth. No, the JAK2 mutation is acquired. And that, again, up to 50% of patients with MF have the JAK2 mutation. More than 90% of patients with P-Vera have the JAK2 mutation. And it's not contagious, but it's acquired. Yeah.
Okay, thank you. And a participant asks, if you take hydroxyurea for a long period of time, does it develop into myelofibrosis?
No, not at all. And one thing that I thought you were going to ask if there was a risk for leukemia. For the longest time at the beginning of my practice, we argue that in every ASH meeting, every December, we had arguments at the ASH meetings, American Society of Hematology meetings, about hydrea. Some people would be passionate about, yes, it causes leukemia. Other people would say, no. Italians, French have a lot of experience with these conditions. They've done trials. Jerry Spivak at Johns Hopkins did trials. Ruben Mesa, Quintas Cardamas, a bunch of people that are experts in these conditions have done trials. And the feeling, over the last 20 years or so, the feeling has been that hydroxyurea does not increase the risk of acute leukemia. So you can safely give hydroxyurea. Why is the concern? Because myeloproliferative neoplasms, myelofibrosis, already have a risk of transformation into acute leukemia. So there was confusion. We feel that if a patient with one of these conditions develops acute leukemia, is because of the disease, not because of the hydroxyurea.
Okay, thank you. I think that's it for the questions that we have in the chat box.
One comment that I wanted to make, because that could also, it has to do with the treatment, because we want to believe that we improve quality and prolong life in patients. That's our goal, cure or at least improve quality of life, or have patients living longer. The first patient that I ever treated with ruxolitinib was a patient that came to me from hospice. It was the father of one of our nurses that had been sent to hospice because he had profound cytopenias, very low red cell count, very low white cell count, and very low platelet count, a huge spleen, huge. And he had been sent to hospice to die in hospice. They asked me for a second opinion. At that point, I was involved in the teaching of ruxolitinib around the country. I was doing talks about using ruxolitinib, which had been approved by the FDA and was beginning to get used in the community. And despite the anemia, because one of the problems with ruxolitinib is anemia, is the main problem. It causes anemia. But despite the anemia, I told the patient that I had to use ruxolitinib, that I had no other option. That patient survived 2 more years. And I'm telling you, he was in a deathbed. All I'm saying is sometimes this drug causes remarkable effects. So it has to be tried. And if the patient is too anemic, now we have pacritinib and fedratinib. So, but fedratinib has to be given with folic acid because it could cause encephalopathy. I'm sorry, not folic acid, thiamine, vitamin B1, because it could use Wernicke's encephalopathy, which is encephalopathy for lack of B1 vitamin. So you have to use it with B1, but they are less likely to cause anemia. So, but the most widely used has been ruxolitinib. And again, I always remember this patient because he was in a deathbed, in a deathbed, and he survived 2 more years with much better quality of life because his spleen shrunk. I mean, his spleen was 30 centimeters, one of the largest I ever saw, and he went down to about 15, 17 centimeters. So he could eat again. The abdomen went down, the edema and all the symptoms went away. So he was able to survive with good quality of life. Unfortunately, we had to continue giving blood because of the anemia, but then we started him on EPO, and he also improved. We stopped the blood transfusions, but he also developed overload of iron. So he developed liver disease. So it's complicated, but the patient survived 2 more years, generally with good quality. So go ahead.
Yeah, I think the point to the quality of life is also so important too with that. We had one more question and then we'll let you go. The question came is, if you have a very low blood cell count, is there anything that can help with that, help increase that?
Yeah, well, it depends on what it is. If you have a low red cell count, we give you erythropoietin, the recombinant product that produces in the laboratory the natural EPO that is made in the kidney in our body. So basically, it's a natural protein. It's called erythropoietin. Shots are called Epogen, Procreate, Aranesp, whatever. We give you that if you have a significant anemia or if you are transfusion dependent. If you have low white blood cell count, as long as you have more than 500 neutrophils, which are or granulocytes, that are the cells that fight bacterial infections, we generally don't do anything. But if you start developing infections or repeated infections, or if the neutrophils go under 500, we may talk with you about using Neupogen or Neulasta, which are growth factors to increase production of white cells. The problem is that if the patient already has myelodysplasia, that could increase the risk of transformation into acute leukemia. So always you have to balance the risk-benefit ratio. You may be able to increase the white cell production, but you may increase risk of acute leukemia. Now, with platelets, you can transfuse platelets, but generally patients do not get into any kind of trouble unless the platelets fall under 30,000. Okay? Many primary care doctors get into a panic when the platelets drop to 70 or 80,000 or 60,000 and send patients to the office right away, an emergency. No. I mean, as hematologists, we can tell you, generally you don't get into any kind of trouble unless the platelets fall under 30,000. And generally you don't need platelet transfusions unless the platelets drop under 10,000. So basically, we are more used to seeing low platelets, and there are drugs that you can give. You can give steroids. You can give artificial testosterone to increase. You can give shots of thrombopoietin-like agents, which is a platelet growth factor. We have Nplate, we have Promacta, so we can use all those. But again, there is always a concern about transformation into acute leukemia, but if worse comes to worse, you can try them. The other thing is that you may have to fight with the insurance company for approval. The insurance company may not want to approve those drugs, so because they are approved for other platelet conditions. So I mean, you just have to. It's an individual decision. These days, in the 21st century, we practice evidence-based medicine, number one, and number two, individualized care. We try to make individual decisions, whatever is best for each individual.
Thank you so much, Dr. Franco. Thank you for joining us today and for sharing so much great information. I'm going to encourage everybody to hang on. We're going to watch a breathing technique video in just a second, but I did want to, again, encourage everyone to, if you want to connect more with Dr. Franco, you can find more information on him at georgiacancer.com with Georgia Cancer Specialists. And again, thank you, Dr. Franco, so much for joining us today and sharing so much information.
Thank you so very much. Have a good day, everybody.
Thank you. All right, everybody, we're going to jump into a breathing technique course with Bev Stangman, one of our facilitators here. This is a class that we currently offer virtually and in person to kind of help reduce anxiety and stress. I also put a link in for today's survey. Please share your feedback with us. We'd love to know what you found interesting about today's program and ways we can always improve. So if you could click the link to share more, and then I'm also going to put in the chat box a couple additional links for resources. So we'll have those there, and I'm going to play Bev's program. If you'd like to connect more with Bev's program or to register for, you can visit our website, cscatlanta.org.
My name is Bev Stegman. I am a yoga teacher and a deep breathing instructor here at Cancer Support Community. Today I'll be reviewing a couple of techniques that you can use to help yourself to reduce your heart rate, reduce your blood pressure, increase your rest and digest response of the body to calm the central nervous system in any situations where you have anxiety, fear, trauma, medical procedures, any or all of the above, or if you're just feeling a lot of stress and tension or worry, these techniques can be very, very beneficial to you both physiologically and for your state of mind. So we're first going to review diaphragmatic breathing. Your diaphragm is a dome-shaped muscle that is an involuntary muscle. It's your muscle of breathing. And when you inhale, the diaphragm flattens down. The lungs, which sit on top of the diaphragm, then can expand. When the diaphragm comes down, the lungs are able to expand to receive air. When you exhale, the diaphragm comes back up to the resting position as the belly draws in, helping to compress the lungs and remove any of the old air and allow the lungs to then be open to receive new air. So we're going to work on calming the breathing accessory muscles, which are the chest and the shoulders. We want to place a hand on the chest to really relax the shoulders down away from the ears and relax the chest and try to get most of the breathing here in the belly. So I'm going to inhale, and as I inhale, my belly's going to come out. My diaphragm's going to flatten, my lungs are going to fill with air. I'm going to pause at the top of my breath, and then I'm going to exhale through my mouth, helping draw my belly back in to bring my diaphragm back up and empty the lungs. Inhaling through the nose. Belly expands, pausing at the top of your breath, exhaling through your mouth or the nose. You can close your eyes if you like. Inhaling through the nose, belly expands, rib cage draws apart, back body expands. It's a three-dimensional breath. Exhale, everything deflates and draws back together. Exhaling all the air, continue to blow out air until you have none left. And then slowly and smoothly beginning your next inhalation, belly comes out, ribs draw apart, back body expands. Exhale, everything draws back together. Go 2 more breaths here. Calming the chest and the shoulders, getting most of the movement at the hand or at the belly level. Exhaling. Gently using your hand to guide that belly in. Inhaling. Belly comes out, rib cage expands. Exhaling, belly comes in. And bringing your hands down to your lap and slowly allowing your breath to return back to normal. Excellent. This practice can make you feel dizzy if you are not used to a deep breathing practice. So take a few minutes before you stand up or move around to just allow your breathing to return back to your normal rate or your normal breath rate. There's also a surge of oxygenation of the body which assists with healing. It assists with immune system function, lymphatic system function, and healing properties of the body, self-healing. All right. We're going to learn one more technique today. This technique is one that I love. It's great to use in situations where you have fear or anxiety, maybe when you're waiting for a scan or waiting to speak with your doctor about some test results, or you have a procedure that may be coming up. Box breathing is also known as Navy SEAL breathing, and it's taught to the Navy SEALs to use in any situations where their body is under extreme stress and anxiety. So it's a tried and true technique. The breath, the breath is done in really any number of breath, or any number for the inhalation, a hold, and then any number for the exhalation, and then another hold. So we might start with a breath of 4 if you're not used to deep breathing. This is a great place to start. And you're breathing in for a count of 4 seconds, holding for a count of 4 seconds, breathing out for a count of 4 seconds, and then holding for a count of 4 seconds. So you can use your finger to actually draw your box as you count to yourself, or I can count for you for your breath. I want you to relax your shoulders down away from your ears, get into a nice comfortable position, maybe bring a pillow behind your back. You can also do this reclined or laying down. Get your feet grounded on the floor. You can close your eyes if you like. We still want to use the belly for the inhale. Belly comes out on your inhale, belly comes in on your exhales. Here we go. You could increase to 5, a 5 count for your box breathing, or a 6 count, or a 7, or an 8, or a 9, or 10. Really, we'll start with 4 just so you can learn it. And here we go. I want you to take a breath in and exhale all of the air through your mouth, continuing to blow out air until you have none left to blow out. Then we're going to begin our inhale. So inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. And relax. So you can draw however many boxes you have time for. You don't have to count out loud. I was just counting for you, but this technique can be very, very helpful. Again, reducing stress and anxiety within the body, fear, muscular tightness or tension, or holding patterns. So I invite you to practice, practice, practice. You will improve. You can maybe build your time up so you're using a 5 count, or a 6 count, or a 7 count. Have a great day, and happy breathing.
All right. Thank you, everybody, for joining us today for today's program. If you would like to learn more about any Cancer Support Community Atlanta events, we invite you to visit cscatlanta.org. If you know somebody who wasn't able to join today's live program, we invite you to visit our website, cscatlanta.org, where the recording of today's program will be. We hope everybody takes care, and we hope to see you soon. Thank you. Bye-bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.